Good afternoon, everyone. Thank you for joining the keynote session for the CASERS 2020. My name is Young Kim from National Cancer Center. I'll be chairing this session. This session, the speaker is only one, doctor, the Professor Andrea Pietrabissa from Italy. Before starting the lecture, I'd like to introduce our speaker today very briefly. First of all, Professor Andrea Pietrabissa is my good friend, the most important thing. Yeah. And Professor Andrea Pietrabissa is now a professor in the University of Pavia, Italy. And then he's now president of the EAES. So he's a big leader in European, not only European, but the world leader. COVID-19, the serious disaster period, fighting with the COVID-19 with all over the world, with all surgeon friends. And today he will be talking about the very important and then interesting kind of new trends of the kind of education. As his title is a patient-specific simulation platform to train surgeons in kidney transplantation. So after his lecture, it actually is a pre-recorded one, so 20 minutes long lecture. And after his lecture, we will have a live Q&A because Andrea Pietrabissa is now online with us, but his lecture will be played with the online pre-recorded one. So please stay, all the participants with us, and then after the lecture, feel free to upload Q&A in the chat screen or Q&A screen. Okay, now could you start the lecture?
Hi, this is Andrea Pietrabissa, and I'm extremely grateful to CASERS, of which I'm a proud honorary member, for the privilege of being here today on behalf of the European Association for Endoscopic Surgery, of which I am the current president. Let me now share my screen with you and start this keynote speech, which is on 3D printed patient-specific simulation platform to train surgeons in kidney transplantation. This is somehow a new topic, and we have tried to explore the potential of this technology in this specific issue of simulation techniques. Now, for those of you who are not familiar with the Italian geography, this is where I am from, the university town of Pavia in northern Italy. The University of Pavia was founded in 1361. It is one of the oldest higher education institutions in the world. Students have the choice of over 80 undergraduate programs, 40 masters, and around 20 PhD courses, which are offered across 18 departments. Out of 22,000 students, about 1,500 are international students, and their courses are taught in English. So Pavia prides itself on the strength of its global outlook, having more than 400 partnerships in place with university and teaching institutions worldwide. Over the past few years, at my institution, we have developed a strong interest into 3D printing technology for medicine. Today, I will address the progress we made in realizing a new 3D printed platform for the training of young fellows in laparoscopic living kidney donation and transplantation. The manufacturing process of 3D printers is based on virtual computer models for the reconstruction of 3D solid objects by the addition of material layers, such as plastic, resins, metal, ceramic, and many others. In surgery, the initial 3D virtual model can be generated starting from the DICOM dataset of a patient's CT scan or MRI. Now, the modeling of soft anatomical parts to teach anatomy was first practiced at Florence during the 16th century. The technique of moulage, as it is properly called, entails the depiction of human anatomy and different diseases using beeswax as its primary material. During the 19th century, moulage evolved into a three-dimensional, very artistic representation of the human body and its internal anatomy, and became popular to have these models available for medical students at many teaching institutions across Europe. These masterpieces combined a deep knowledge of human anatomy with a true artistic sense for the beauty of nature. 2 centuries after that, we are today attempting, in a much less artistic way though, to follow a similar path, at least in the belief that 3D models can still be useful, not just for the study of anatomy, but also for a number of medical and surgical applications. The growing interest into 3D printing in surgery is testified by the number of papers published in the last few years that shows a clear upward trend. These reports are mainly focused on solid organs and major vessels, whose models are more easy to build. And the prevalent reason to create 3D anatomical objects were reported to be surgical planning, education, and training, but also patient counseling. At the beginning, we have also explored the possibility to fuse these 3D models in an augmented reality environment during surgery. This video dates back to more than 15 years ago. But however, these attempts have many significant limitations, such as precise matching between preoperative data and intraoperative view, intraoperative shifting of organs that will move with respiration and by surgical displacement, and accuracy. And accuracy has to be extremely sharp to be efficient in performing the surgery we need to do. So more recently, we have established at the University of Pavia, within our hospital, a laboratory, clinical laboratory for 3D printing. This is an exposition area which is in front of the laboratory in the main lobby of our hospital to present our activity to visitors and patients and relatives. The laboratory is fully equipped with industrial 3D printers, and we have a group of biomedical engineers working full-time to produce objects like this. This is our 3D printed guest book, and you are welcome to sign the book if you pass by and visit us. Now, these are some examples of the printed material that comes out from our laboratory. So this was done for our vascular surgical fellows, and of course it's an aorta with a prosthesis in place. Orthopedic surgeons are good customers of our laboratory. This is a complex fracture of the hip bone, and by having this model in their hands, orthopedics can produce can actually be able to anticipate the fixing of this fracture the day before surgery. The same applies to maxillofacial surgery. This is an orbit defect, post-traumatic orbit defect, and the missing part was also printed in nitinol. before the actual surgery. This is an aneurysm of the pulmonary artery, which was removed by our cardiothoracic surgeons. And again, this is an intracranial aneurysm with a very complex vascular supply that had to be carefully planned before surgery by our neurosurgeons fellows. This is a model of a lung cancer, very close to the hilum, to the vascular hilum of the lung. And again, we have been asked by the thoracic surgeon to produce this model, and this happens very often, actually. Additionally, we also produce livers. And now the problem with liver is that to be able to see the intraparenchymal vascular network, we need to use transparent material. And transparency, because of the density of the material, produce significant distortion. So this is something we are working at also by producing interlocking type of printout. This is again an example of a recurrent vascular tumor at the joining of the right hepatic vein with the IVC. The purple mass there is the tumor, again in this very tricky part of the liver. And it was helpful to have this model in planning for the surgery, and you can see the surgical specimen with the tumor, the IVC which was removed, and then the liver was sort of auto-transplanted in a piggyback way on top of a replaced segment of IVC. So this is a type of surgery that need actually very careful planning beforehand, and the procedure was done together with the cardiac surgeons. Another field of application is the total mesocolic excision for the right hemicolectomy in those patients at risk of local recurrence. And as you know, the anatomy of this region is very variable, and so the possibility to have print out these models beforehand allows the surgeon to bring the model with him or her in the operatory room and be absolutely sure of what type of vessel he has encountered and ligated and what the next challenge is likely to be. Then we come to our topic of today, which is kidney transplantation and training for kidney transplantation. Now, as you know, the current practice of live donor kidney transplantation entails a laparoscopic or robotic, depending on your preference, a nephrectomy, live donor nephrectomy. Now, one of the issues in live donor nephrectomy is the use of staplers to transect the vessels, and sometimes you can have an early bifurcation of the artery when you have a single artery that makes the use of a stapler somehow complex. And in this case, for instance, you can test the stapler on the model and see that if you use the stapler, you will end up with two vessels instead of one. So intraoperatively, we already know that we had to go for a different solution, which is using a large hemolock so as to have a sufficient cuff of tissue to be transplanted. Then for extra safety, we overrun the little stump of this vessel because staples by themselves cannot be used to fix the renal artery alone. So you need a transfixing system like the one I show you with the robotic approach. And but then in more recent times, we have tried to use different type of 3D printers. 3D printers that are able to reproduce deformable materials. And the deformable materials will react mechanically as the real tissue they have been derived from. And this opens new avenues, not just for pre-operative planning, as we have been using 3D printers so far, but also pre-operative patient-specific simulations. So you can use these models to dissect, cut off, and suture as if they were the real tissue you will approach during surgery. And here's an example again. This is the aorta of this left kidney. It's a left kidney for life donor nephrectomy. And this patient, as you can see, has 2 arteries and 1 vein. This is the splenic artery. And the kidney parenchymal has more stiffness than the vessels because we ask the printer to produce this type of object. And again, the mechanical performance is very similar to that of the real kidney. So this is how it looks intraoperatively in the real patient, and how we were able to simulate this procedure the day before surgery. So the distal artery is clipped with an hemolock and then transected to preserve a long segment of this vessel. And the same was anticipated pre-operatively in this in vitro model. So a clip, an hemolock clip, is placed at the bottom of this vessel, and then that is cut on top of the clip. And it has a internal lumen as the real vessel has. Then the main artery is secured with a linear stapler. And again, this passage had been anticipated beforehand by simulating the same thing with a stapler on our 3D printed object. And also, one technical challenge of this procedure is how are we going to reconstruct this vessel. Sorry, it seems that, let me just go back for a second. We didn't run the old video. So let me see if I can run this video again for you. Right, I hope you can see that better. And again, this is transecting of the distal artery. I think the combination of recording a video and playing a video at the same time has put some extra challenge on my laptop. I apologize for that. Hopefully this will run till the end more smoothly. And for a second, we didn't run the old video. So let me see if I can run this video again for you. Right, I hope you can see that better. And again, this is transecting of the distal artery. I think the combination of recording a video and playing a video at the same time has put some extra challenge on my laptop. I apologize for that. Hopefully this will run till the end more smoothly. And so distal clip, transecting, and then stapling the main artery. Okay. And then again on the model, we'll staple the main artery on the model. Okay, it doesn't run. I'm sorry about that. We'll keep for a second. We didn't run the old video. So let me see if I can run this video again for you. Right, I hope you can see that better. And again, this is transecting of the distal artery. I think the combination of recording a video and playing a video at the same time has put some extra challenge on my laptop. I apologize for that. Hopefully this will run till the end more smoothly. And so distal clip, transecting, and then stapling the main artery. Okay. And then again on the model, we'll staple the main artery on the model. Okay, it doesn't run. I'm sorry about that. We'll keep on going. So anyhow, it was possible also to simulate the vascular suture of the two arteries on the side table before the real procedure took place. And then we decided to create this quite complex model for the transplantation, not just the donation, but also the transplantation. And these models entails the production of the ilosoas vessels, of the bladder, of the bones, and of the vessels. And the vessels can be replaced on the site of decided for the transplantation. Now, this is the original version where the vessels have been printed according to the anatomy of the recipient. But in trying to use these vessels for simulation, we had problems. And the problems is that the printed photodynamic resins is not ideal for vessel suturing. And I'm going to show you in a moment what the problem was like. That's the ureter that joins the bladder. And this is the fully assembled model. Everything has been 3D printed with different type of texture and density of the tissues. So the next step was trying to do in vitro transplantation. And this is how it looks like. So again, these vessels on the right-hand side have been fully printed with a 3D printer. And this is the kidney, again, is a patient-specific kidney. That's the ureter, and you can see the artery at the bottom. But the consistency of these vessels is not the same as you would have in the human situation. The degree of stiffness is higher, and then as you as you try to suture these vessels, the thread breaks through, and so it makes very complex for junior fellows and residents to perform these anastomosis. Actually, it is more difficult than in the real situation. As you tie the suture, it tends to break through. So we felt this was far from ideal. And we decided, you can actually see here how the needle and the suture breaks through this, let's call it tissue, which is a photodynamic resonance. And so the suture is far from ideal. So we decided to go for a different type of material by dunking those vessels into latex. So if you dunk these vessels into latex, and you can see from the, let's say, renal vein side, the one held by the surgeons, then the vessel increase their stiffness, and the quality of suturing is very much the same we will have in the real situation. So it will hold the suture very well, and you can suture, tie knots, hold the back of the running suture without the risk of breaking through. And so we applied this system to the final version, and this is the final version. So the old procedure is screenplayed in the OR. We have a scrub nurse, a first assistant. The only thing we don't need is the anesthetist. But then the junior trainee is asked to prepare the surgical field, to have his own first assistants, and we are currently assessing the quality of this educational tool by having 2 of our junior fellows doing 20 transplants each by sweeping over. One time I am the surgeon, the next time I'm the first assistant. And that is before having these people doing the current real transplantation in humans. And I've not had yet the data, but this is how it looks like. This video shows you how the operation is done. So the skin is cut, and then the peritoneal fold is displaced to expose the vessels and the muscles. Then the retractors are put in practice. The excess renal vein is taken out, and then the operation is done in an open fashion. But then the vein and the artery and the ureter are transplanted as in the real situation. So the trainee has to go through all the challenging part of this operation, learning how to go from one step to the next one, learning the team leading capabilities that he has to develop in being able to perform this operation. And we are very satisfied with this type of simulation, which is not just a technical simulation, but it's a simulation also of teamwork. And that's the way we should go for it. This is the first of many other simulating setting that we are trying to put into practice. The next one we are working at is TATME for rectal cancer. And we are also developing at the same time a transanal approach to TATME, and that will shortly be available in our institution. So this brings me to the end of my talk. And in concluding, I would like to stress that the technology of 3D printing for general surgery represent a very interesting and promising tool for best delivering of the anatomical information from radiology to final user. And the final user is not necessarily just the surgeon. It are many types of surgery, but also we have had good collaboration with cardiologists, with medical legal fellows, with anatomists for teaching anatomy to our students, and many, many others. And that's just one part of it. As if we want to take this one step forward, I think the frontier would be in vitro simulation of patient-specific procedures, surgical and medical procedures. There are open questions, though, and that relates to the cost and the time it requires to create these models. My suggestion is not to see 3D printers as a tool for surgeon. 3D printers laboratories must be seen as a facility for the hospital, and that's the way we have implemented that in Pavia. So our hospital has seen the 3D printing clinical laboratory as the radiological laboratory. It's a facility for the whole hospital. In that way, you can reduce the cost and you can spread the value of this technology to many different specialists. It is currently mostly limited to solid organs and major vessels, but this is likely to be overcome in times, and also cost will be reduced in times. Of course, you need a dedicated team of engineers, of biomedical engineers, but that's true for also many other settings in surgery. We are not any longer alone in doing this, and also in the OR we need additional people trained in different technical tools, and so the combination of surgeons and engineers is something that will more and more come with our profession. So I'm very grateful once again to K-Cells, and I hope you enjoyed this presentation. It's very sad that we are forced to talk one each other to these virtual platforms, but this is much better than nothing. And all major society have been forced in these challenging times to cancel our meetings and to keep on our relationship through virtual channels. And I must say that we have been as close as never before, and including K-Cells, we have been connected through the hot times of these pandemics almost on a weekly basis. And that has made our friendship closer than ever before. We should continue in this fashion also for the future, and I hope we'll be able to shake our hands again, perhaps next year. Thank you very much for your attention, and enjoy the rest of this meeting. I'll be happy to answer any specific question you might have on my presentation. Thank you.
Okay, thank you very much, Professor Andrea Pietrabissa. What can I say? It's just fantastic. I saw the future of the surgery. I think it must be very important in the future surgery to improve the patient's safety and also improving the efficiency of the education of the training. Okay, so now this session is open for the question and answer from the participants. Please don't hesitate to upload any questions. See some questions?
Okay, let me say, just to break the ice,
Okay.
the reason for we decided to start with the kidney transplantation has to do with the difficulty of training for junior fellows in this situation. Of course, in doing a kidney transplantation, you must be very efficient as far as time and as far as precision. There's no mistake allowed in that situation. It's not like, doing a colectomy. You can have a junior fellow or a resident doing part of the procedure, and if it takes longer, who cares? And also, mistakes are allowed because you can fix them. But this is not the case for transplantation. Everything has to run very smoothly and quickly. And therefore, it's a typical situation where we need ex situ training. And all the models available for training are far from ideal. And so we felt that reconstructing not just the stitching tool, but everything, including the OR environment, the stress of being the surgeon with someone helping you, the scrub nurse, all that situation is a challenge. And for junior fellows, being able to control the situation, to get used to this every single step, prepare them very nicely. And in the next few weeks, we'll start having these people doing the real transplant themselves because they are ready. They've done 20 each, which is very good. I didn't have time to show, but we record the time and the quality of the performance that has now reached a plateau. So after 16 transplants each, they reach a plateau, which is very good in terms of quickness and quality of suture. And I feel they are ready to do that in humans. So we'll test this shortly and let you know.
Okay, amazing, amazing. Andreas, Andrea, so improving the kind of accuracy of the surgery is very important in transplantation. But I think maybe the oncological surgery also in the future, the I think is could be applied for the oncological surgeries to improve the safety and then the kind of thickness and then kind of the good quality surgical outcomes after the surgery. So what is your kind of your expectation or future prospect of this kind of 3D printing technologies in the surgery? I felt, because of the consistency of material limitations of this 3D printing currently, there must be some room to improve in the technological aspect. Also, and not only just the technological kind of limitations, but also maybe, I mean, the kind of is reproducing all those kind of similar situations in operating room, not only kind of anatomical, but also many aspects of the operating rooms could be simulated in the future. So I think not only for the safety of the surgery, but the training and education platforms also could be changed by this 3D printing. So what is your kind of expectation?
Well, obviously, I'm sort of passionate with this technology, and which is quickly evolving. At the very beginning, we felt that 3D printers were only useful for preoperative planning. To have those rigid models in our hands might help more than simply watching a CT scan, a conventional CT scan, and that was the beginning. But then technology surprised us because the evolution has been very quick. And we now have this new type of materials where you can choose the color and you can choose the consistency and make it similar to the original tissue the reproduction comes from. And that opened new gates for simulation, as I showed you. But what the technology and the development will bring in the near future is really hard to predict, as it applies to many other type of technology. Let's think about cell phones. If you would ask me what is a cell phone for 15 years ago, I would say to make phone calls. But we use cell phones mostly for other reasons. We
Right.
navigate, book tickets,
Yeah.
we check on everything, forecast, and so on. And that was unpredictable. And the same, I think, is for this technology. What makes me confident that there is a future is the increasing interest in hospitals and surgeons worldwide. We have set up now a network of 3D printing laboratories, which is quickly developing and increasing in numbers. There are many centers now in the UK, in the Netherlands, in Japan, in Taiwan, in the US, that are implementing this technology to assist not just surgeons, to assist hospitals in delivering a better care and better training. So
Yeah.
I think there's a future there, but time will say.
Yeah, and I found you developed a very good idea, kind of a 3D printing labs, and then you centralize all the services in the one specific unit, and then everybody could use and utilize that. Cost could be down, and then must be efficient. It's a very good idea. Yeah.
Yeah, at first you think this is my toy.
Right.
I want to put this in my unit because it's mine. That's natural. But it's a wrong way to go. Uh, Making this technology available for the all hospital not only reduces cost, but we have discovered new field of applications that we wouldn't know before. We have been asked by cardiologists, as I say, to produce models for delivering intracardiac umbrella, and they are doing that in a simulation system. And also our intensivists needed models to train their fellows in alkalizing a stellate ganglion percutaneously. So we made this model, which are ultrasound sensible, to train people in difficult tasks, and many, many more things. So it was really, I think, a smart move to make this facility available as the lab, as the radiological unit, which is not just for us, it's for everybody. And that reduces cost as well, as you said. So that's my advice for anybody willing to embark into 3D printing technology. Make it a hospital facility, not your own printer.
Yeah. Okay, Andrea, we're already behind the schedule, but fortunately we have a 30 minutes break that people are remaining in this conference room. So thank you for the participants. But anyway, we need to wrap up this session. So I really appreciate really eye-opening and inspiring lecture for our Korean surgeons. Thank you so much again, Professor Andrea Pietrabissa, and I hope we could see in person soon, very soon, after this
Hopefully we'll
COVID-19.
shake our hands again in the near future, no doubt. Thanks for inviting me.
Thank you. Thank you so much. Thank you.
Thank you.
Yeah, thank you. Thank you so much. Bye-bye. Thank you.